Good afternoon, sir. Probably I'm here. You can hear me, sir.
Right. Please
Okay.
correct.
Good afternoon, respected chairpersons, co-chairpersons, moderator, the honorable panelists, and all are here who will be taking care of all the patients of our countries. I'm Tariq Reza Ali, and I got so much support from Dr. Raja Narayan and to prepare this presentation. He is my consultant during my fellowship at LV Prasada Institute. So as we all know that this surgical aspect of the management of diabetic macular edema, before presentation, I want to tell that diabetes is a cause, that is diabetic patients have much more different vitreous than the non-diabetic patients. And these vitreoretinal interface abnormalities are present there for diabetic macular edema. The firm adherence of disc and macula to the posterior hyaloid, and during stretching or during PVD induction, there may be blood retinal barrier breakdown, inner blood retinal barrier breakdown, and this can cause one scaffold for cellular proliferation. This internal limiting membrane of diabetic vitreous is much more adherent to the central cellular elements. This internal limiting membrane is thicker, and more heparin sulfate proteoglycans are present. And also the biopsied ERM showed that there is much more fibromuscular cells present in the ERM, which can cause traction on the vessels of the macula. So increased cross-linking and protein glycation causes tangential macular traction, and adherent vitreous, which is adherent to the macular blood vessels, can locate the mediators of vascular permeability, which can impede the oxygenation of retina for upregulation of vascular endothelial growth factor and thereby vascular permeability. How does vitrectomy works? It is at least theoretically that vitrectomy increases the intravitreal and inner retinal oxygen level. It downregulates the VEGF synthesis, and it opens compartments of loculated cytokines, and it relieves traction exerted on macula. Vitrectomized eyes with DME have a lower prevalence of PVD than eyes with DME. And after the advent of OCT, it is clearly shown that vitreomacular adhesion is a risk factor for development of diabetic macular edema. If this patient comes to us, probably we have no doubt that we have to go for pars-plana vitrectomy. But this patient, we can try with injection anti-VEGF. But if this patient, if there is a doubt whether we will go for injection or we will directly go for pars-plana vitrectomy. Let us see one patient. This patient had only cataract, vision was 20/60, and other eye was pseudophakic. After the cataract surgery was done, the first POD vision was 20/20, but after 6 months, the patient came with very less vision, 20/80, and we decided for injection Avastin 3 doses. After Avastin, vision did not improve after 3 months, 2 months after injection. So we decided for intravitreal steroid. And after steroid, after 1 month, vision was a bit improved to 20/40, but again, after 6 months, the vision again decreased to 20/200. So we decided to go for surgery, pars-plana vitrectomy, ILM peeling, and fluid gas exchange. And this surgery is very simple surgery. You all retina specialists can do this type of surgeries after vitrectomy. Then ILM peeling and fluid gas exchange was done. And this patient, after 1 month after pars-plana vitrectomy, the vision improved to 20/80, and after 1 year, the vision came to 20/30. This may be a success story for a pars-plana vitrectomy, but let us see another case. This is a 51-year male, diabetic for last 10 years on oral hypoglycemic agent, not properly controlled diabetic. He's also hypertensive and hyperlipidemia. The vision was 20/80 in right eye, 20/20 in left eye. And after, this is the FFA, shows hyperfluorescence. This is the early and this is the late. And the OCT also showed that cystoid macular edema in right eye. So we planned for injection anti-VEGF in right eye and to observe in left eye. 2 months after injection, the vision did not improve much, 20/60, and left eye maintained 20/20. And after that, the patient lost for follow-up for at least 1 year. After 1 year, when he came back, vision was 20/60 in right eye, but left eye vision was 20/40, and there was huge cystoid macular edema in both the eyes. So we decided for injection anti-VEGF. We planned for peritoneal coagulation, but the patient developed vitreous hemorrhage. So we have to go for personal vitrectomy and ILM peeling, and everything was done. But the vision did not improve to this patient after 6 months of surgery. This is not a very successful story after personal vitrectomy. This is the surgery of Dr. Rajan, and he did that is OCT guided ERM peeling and membrane peeling. This is not available with my setup, but this will be helpful for other surgeons to do this OCT guided personal vitrectomy. Another surgery by Dr. Raja, he did it with that is bimanual vitrectomy. And that is another with chandelier light. He did this bimanual vitrectomy. It was done, and we can also do this type of surgeries if needed. Here it was a very thick ERM, so it needed for bimanual surgery. Very thick ERM, it was cut, and the surgery was done. So vitrectomy in diabetic macular edema, the real world scenario is, it was first reported in literature in 1992. After that, series of cases and trials, but there is no RCT till now. So eyes with taut posterior highlight or failed previous laser, they went for personal vitrectomy. Attached but non-thickened posterior highlight, that those cases are also done personal vitrectomy, and also persistent DME despite laser or intravitreal injection. And vitrectomy relative frequency was refractory DME with PVD, refractory DME with taut posterior highlight, refractory DME with ERA. Does it really work? Another 1 minute, please. Controversy exists. Vitrectomy reduces macular thickening, but does not improve the visual acuity. The improved visual acuity with decreased macular thickening for a few months. Somebody reported that improved visual acuity with macular traction, but no improvement without traction. So this review article tells that though there is an improvement of 2-letter visual acuity difference during favoring vitrectomy, but after 12 months, this central retinal thickness actually it reversed. So most frequent complications are also retinal break and intraocular pressure rise, and also cataract developed by 68% patients in phakic patients. So conclusion, vitrectomy produces structural and functional improvement, but probably there is no gain significantly in vision or than laser or intravitreal injection. So probably vitrectomy is not advisable, at least in some countries, as primary therapy of diabetic macular edema. Thank you, ladies and gentlemen, for